Good evening, everyone. It's a great pleasure to have you all here. I'm Dr. Omkaro, working as a medical advisor at Hetero Healthcare. Our topic of discussion for today is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding of the postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years and has more than 300 products in its portfolio. It has 21,000 employees globally, and it is also among the largest manufacturers of ARV, API, and FDF in the world. It also has 36 state of the art manufacturing facilities and has its presence in more than 126 countries. Hetero also has the Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero also has a distinction of bringing four biosimilar products to market within 5 years of initiation. Now, I would like to introduce both our speakers for today's meeting, that is Dr. Suhail Iqbal sir and Dr. Javed Khurshid sir. Dr. Suhail Iqbal sir, who will be speaker for today's meeting, is currently working as a consultant gynecologist in Baramulla since 2019. He has done fellowship in minimal invasive surgery and also in urogynecology. Welcome, sir. Dr. Javed Khurshid sir is currently working as a consultant anesthesiologist and has overall 15 years of experience. So, with this, I welcome both the speakers. I welcome all the delegates who have joined the meeting and hand over the session to Dr. Suhail Iqbal sir. Over to you, sir. Dr. Sohail sir? I guess sir is having some technical difficulty with
Yeah, I
his
think
network.
Dr. Suhail has left the meeting for some reasons. Okay.
Okay.
Le- Uh,
So I guess we can just wait a few seconds,
yeah.
30 to 40 seconds. I guess he would be joining again. So
Okay, okay. Let me call him. I'll call him. Okay, should I call him?
no problem, sir. I guess our team would be in touch with him. I guess our team would call him.
Okay.
So our team has spoken with our team has spoken with the doctor, so he will be joining in just a couple of minutes, I guess.
Okay, okay. कर video on.
Hello.
Hello, am I audible?
Yes, you're audible, sir.
Okay, okay, okay.
So, sir, I have just introduced the agenda to all, and now I hand over the session to you.
Okay. Today we'll discuss, today we guys will be discussing PPH. Uh, okay. I am Dr. Suhail. I'm a gynecologist working in JNK Baramulla. So we are going to discuss PPH today. So first we'll be discussing definition of PPH. What is PPH? PPH is loss of at least 500 ml of blood during normal delivery or more than 1000 ml of blood, 1 liter of blood after C-section. This is the most common definition we use for PPH. PPH is common and can occur even in women who are not at risk. PPH is the leading cause of MMR in low income countries and primary cause of nearly one quarter of all maternal deaths globally. So the third world countries like Sri Lanka, India, Pakistan, Bangladesh, Afghanistan, women living in these countries, they have more morbidity and mortality due to PPH. And the women living in like Western countries, they they have less, they also suffer from PPH, but the morbidity and mortality is less there as compared to in Asian countries and poor countries. Next slide, please. So post MMR is the leading cause of maternal mortality, accounting for almost 35% of all the maternal deaths. And MMR in developing countries it was 240 per 1 lakh live births compared to 16 in developing countries. 14 million women suffer from PPH. Incidence of PPH is reported to be 2 to 4% after vaginal delivery and 6% after C-section. 38% of the MMR are due to the PPH. 25.7% of the global deaths take place in India, and two-thirds of these attributed to PPH. India has unexpectedly high maternal death rate of 540 per 1 lakh live births. So next slide, please. So the most common cause of PPH is atonic PPH. The other cause, second most common will be traumatic PPH or iatrogenic PPH. The third cause is thrombin. The third cause will be retention of placenta and clots and RPOCs. And the fourth common cause is thrombin, coagulopathies. Patient having low thrombin levels, or patient who have von Willebrand disease, patients having these factor A deficiencies, protein C, protein S deficiencies. This is the last common cause of PPH. Next one, please. Clinical findings in PPH. The early findings will be patient can have palpitations, dizziness, and tachycardia. Then it is the compensatory phase. During this, almost 500 to 1000 ml of blood losses occurs in the patient. The second will be mild form of PPH, during which 1000 ml to 1500 ml of blood loss can take place. Uh, During this phase, patient can have weakness, sweating, tachycardia. She can have this dryness of mouth also. She'll be having pain also. Then will be the moderate form of PPH. During this phase, patient can have blood loss of almost 1500 to 2000 ml of blood loss. So BP will fall around 70 to 80 mmg of mean arterial pressure, MAP, which is then the during this phase, patient can have oliguria. She will have pallor, then restlessness, dizziness. Then the last phase, during which patient can have blood loss of more than 2000 ml. It will be around 2000 to 3000 ml, and patient have profound fall of mean arterial pressure. Patient will collapse. Patient can have air hunger, anuria. Patient will be on can be also on ventilator, or the patient during this phase. Sometimes we need this dialysis also. Next one, please. So approach during PPH. During PPH, the first thing we do is uterine massage. I will not go according to the slides. I will tell you what we do normally in the hospitals during if the patient will have PPH. First, we will go for uterine massage. Wait a second. Sorry for the disturbance. So if the patient is having atonic PPH during this phase, what we do normally in the hospitals, we first try to find out the cause of PPH. If patient is having atonic PPH, then we will go for uterine massage. We do bimanual massaging. First, one of the hands will be in the vagina, taking the uterus upwards, then the other hand will help in doing the uterine massage, or keep the uterus between two fingers. One will be vaginal and other will be holding the fundus of the patient. Then we try to stop the blood. During this, while doing the uterine massage and this uterine massage and other maneuvers, we till that time we inform the assistants also. And if the patient is having, we will discuss it later. During uterine massage, one of the sisters or the lab technicians, they will take the blood sample and we will send the blood sample for CBC count, coagulation profile, and then also for electrolytes and LFT, RFTs also. Then no. After fundal massage, we try to give drugs for the PPH. The drugs we normally used to give before, it was oxytocin, also methyl ergometrine, methergin, also prostagine, PGF2 alpha, prostagine injection. Uh, then also we give tranostate sometimes. These are the first line drugs which we give. Nowadays, the new analog has come, uh, carbetocin. Although people in Western countries were using this drug like 7 years before. Why I saw this drug in 2017 only, while I was doing this my PG in RUH Rajasthan. Then after this primary treatment, anesthetists will also help if patient is having C-section. Anesthetists will help us help us in managing the uh, other uh, other these. If the for example, if patients having low BP, the anesthetist will give poloids, crystalloids. Anesthetist will give also this oxytocins also, oxytocic agents also. Then after that, if the patient, if it is normal delivery, we give we do uterine massage, and then till that time we will give drugs also. Drugs will be if the we give prophylactic drugs like oxytocins, prostaglandins, and alkaloids. Every drug has its own benefit and it has own side effects. Like we can't give more than 40 to 50 mg, 40 to 50 units of oxytocin. It will there will be a phase it will decrease the BP of the patient. Also, it will lead to pulmonary edema or water retention. Also, prostaglandins they can cause ear embolism. They have this side effect. Ergot alkaloids like ergometrine, methyl ergometrine, they have the side effects, or they can lead to cardiac arrest. If we can't give this drug methyl ergometrine to patients having PIH, pregnancy-induced hypertension, and oxytocins. It will if patients has low BP, so it will also decrease more BP in a patient blood pressure. So every drug has a benefit also and a side effect also. Then for coagulation, if patients we give also tranostate also. We keep in consideration that patient may also be having this coagulopathy. Then if delivery is happening in a labor room and we have if any of the guys have this portable ultrasound in the labor room, we do ultrasound also to exclude intraperitoneal or extraperitoneal bleed. We will discuss it later how to diagnose intraperitoneal, extraperitoneal bleed in a patient. Then after that, if patient is having iatrogenic trauma, iatrogenic delivery, then we have to treat the iatrogenic causes of the bleeding. First, we have to control the source of bleeding. For example, if patient is having uterine rupture, we have to go for laparotomy. Then we will try to close the rent, or if patient is having complete uterine, we have sometimes we have to go for abdominal cesarean hysterectomy also. So sometimes if the ankle is bleeding or the any other part is bleeding, we try to sieve that part. We try to suture that part. Tears during C-section, they are normally every if patient knows how to do C-section, that doctor will also knowing how to close the angles and how to stop the iatrogen causes. Then sometimes one of the cases while I was doing my PG, I saw patient having normal vaginal delivery. Then the patient had this uh, cervical tear. It extended up to the fornix. Then one of my guides, she opened the patient. We went for laparotomy. Then we saw the patient is having broad ligament. Tear has extended up to the broad ligament also. So that time we have to uh, close the vessels, or we have to uh, ligate the vessels in broad ligament. And then if fornix is bleeding, we have to save the fornix also sometimes. So you should be generally having those expertise of doing those surgeries. If it is sometimes supralevator injuries and below the broad ligament, we try to observe the patients in those conditions, and in that time we try to give this we go for embolization of arteries, the artery which one is bleeding. And then after that, if patients having like during vaginal delivery, patients having cervical tear or vaginal tear, so better is to take the patient to the OT, go for spinal either local anesthesia, spinal anesthesia, or patient can be take can be taken for general anesthesia also. Then it will be better to suture the patient under anesthesia. Normally, while suturing under local anesthesia in labor room, that is not the results are not better, and sometimes hematoma formation can also be there. Then after that, uh, ultrasound is will be very helpful in those cases also, like identifying the cause of identifying the not the cause, identify the place where the hematoma has occurred, like in supralevator or infralevator places. Then after that, for retained tissues, ultrasound examination can be done. We can check RPOCs, retained products of conception. For that thing, if placenta is drained, we can go for MRP, manual removal of placenta, or if tissues are there, then we can remove the tissues. Either better will be under anesthesia if you remove the tissue, because it's a painful condition while removing the RPOCs. Then, if coagulopathy is sometimes, I had one of the patients who had hematoma in the uterus after C-section. Then, patient was bleeding for 10 to 20 days. She was bleeding little bit, and we gave her imatinics and every drug we gave, cytolol, misoprostol, everything to control that bleeding. We also put patient on hormones also, but that hematoma was there. It was neither increasing nor decreasing. Then after that we went for coagulation profile. Already we did before surgery, we have already done this coagulation profile, but it was showing nothing. It was normal coagulogram. Then after that we repeated coagulogram at two more centers. Then one of the best centers showed us the patient was having APTT of 80. So that patient was given 2 units of FFP. Then the patient recovered in a single day only. This is the wonder we have with this. If coagulopathy is diagnosed early, the patient will have less morbidity, and also uh, this hematoma or any other complication will be reduced. Then after that, uh, with atonic PPH also, I will show you guys what I do. Sometimes during cesarean section, if drugs don't control the atonic PPH, then I have this also. I use this suction cannula. This is known as PPH cannula. I put through the vagina. I put inside the uterus, and then after that we keep this for some time till the tonicity of the uterus is achieved and the bleeding is controlled. Sometimes I use this also. Burki's balloon. This is the thing you get in 2 to 3,000 rupees. So you have to keep this also. If you are working as a private consultant, keep this thing with you, and this thing also. So if you are working in a less resource place, and if you are not working in a government hospital, then you keep these things. It will help you in managing the PPH. Also, if bleeding is not controlled with suction cannula as Burki's cannula, then we go for this suturing. We do this. We give Cho suture, B-link sutures. First, personally, I do B-link sutures first. Then, if bleeding is still not controlled, then we go for Cho sutures or scat sutures. Also, uterine artery ligation. First, I go for uterine artery ligation. If still it is not controlled, then B-link sutures, the Cho sutures, cat sutures. If still it is not controlled, then I go for ovarian artery ligation, and I ligate also vessels in IP ligament also. Then still, if it is not controlled, then I go for interiliac artery ligation. So I learned this thing during my fellowships, how to ligate this internal iliac artery, and then this ovarian and other vessels. This is the thing. Then next slide.
عندي مش leaking pain ولا corona.
Then the difference, it's a comparative study showing us the comparison between oxytocin and carbetocin. So oxytocin, we know we have always to keep oxytocin in refrigeration. We have to maintain the temperature between 2 to 8 degrees centigrade. So the countries with low resource, sometimes this cold chain couldn't be maintained. So because, for example, in India, if I'm living in Kashmir and manufacturing of oxytocin takes place in Delhi, so they have to bring these injectables from Delhi to Kashmir in a refrigerator. So we need big those vehicles which have refrigerator inside. So sometimes the cold chain is not, if sometimes cold chain is not maintained with the pharmacist also, or with the stockist, sub-stockist. So the problem with oxytocin and other alkaloids is this refrigeration only. Cold chain is not maintained. While the carbetocin, We don't need to maintain the cold chain. And also the shelf life of carbetocin is 24 months. So it can be kept at 30-degree temperature. We don't need to maintain the cold chain and storage for this patient for the drug. Next slide. So when hydrotonic agents can be given, hydrotonic agents, different hydrotonic agents can be given at either the crowning of the baby's head or at the delivery of the anterior shoulder of the baby or at the end of the second stage of labor following the delivery of the placenta. Uh, Eutotonic agents can also be given for prophylaxis, like for prevention of PPH or AMTSL, active management of third stage of labor. Or it can be given therapeutically also for the management of PPH. Now, with normally I prefer after removing the placenta, I deliver while I deliver the placenta. After that, we give oxytocin. Sometimes, if the patient is having no. I used to give this oxytocin before after delivering the placenta. Nowadays, I give after the shoulder is delivered, which is known as active management of third stage of labor. Either we give 4 units of oxytocin. Sorry, oxytocin can be given. Better is to give before the delivery of the placenta. If we can give oxytocin 5 units, either IV or carbetocin 100 microgram can be given IV or IM. So methergine can be given 0.25 mg, but methergine is not a suitable drug. It will lead to tachycardia. It will lead to increase in BP. Sometimes the patient will have chest pain also with methergine ergometry. Then sometimes people give a combination of methergine and oxytocin. Uh, I don't consider this as a good regime. Better will be either you give oxytocin 5 units or carbetocin 100 microgram. After that, after delivery, after delivering the placenta, misoprostol 600 mg can be given also per vaginally in patients. Either vaginally or per rectal can be given also. Either normal delivery or C-section. Next slide, please. Now Carbetocin. Carbetocin is almost analog of oxytocin, but with these differences. This is a synthetic long-acting analog of oxytocin. Therapeutic indication is prevention of PPH, posology, and administration. One vial contains 100 microgram of carbetocin in 1 ml solution of injection. It can be given either IM or IV. Next. Both oxytocin and carbetocin, they bind to oxytocin receptors, but in oxytocin, IV after IV dose, peak concentration occurs after 30 minutes, but in this carbetocin, it occurs in 2 minutes only. Then rhythmic contractions can occur up to 60 minutes, while in this oxytocin, it occurs only for 30 minutes. One is sustained uterine contraction. The other one is rhythmic contraction. Sustained contraction occurs within 2 minutes with carbetocin, while in oxytocin, sustained contraction occurs in 30 minutes. 30 minutes is a huge time. Till that time, this patient can lose huge amount of blood. Then after that, uses of carbetocin and it is a comparative study also use of carbetocin and oxytocin. For induction of labor, yes, both can be used. No, sorry, for induction of labor, oxytocin can be used, but with carbetocin, it can't be used. Augmentation of labor, yes, oxytocin can be used, but not this carbetocin. For prevention of PPH, both can be used. For the treatment of PPH, both also can be used. They have written no with this. It's a mistake in the slide. Next slide, please. There was a trial for the it was a trial was conducted by WHO, which is known as WHO champion trial. And two drugs were compared. One was oxytocin and other was carbetocin. The objective of the trial was to compare the effectiveness and safety of carbetocin and oxytocin. The drug was tried in 30,000 women across 10 countries. So the outcomes were the proportion of blood loss was at least 500 ml or the after use of uterotonic agents. The proportion of women with blood loss of at least 1000 ml. The people who were having more than 10,000 sorry, more than 1000 ml of blood loss, which after using the oxytocin like carbetocin, this patient had less amount of blood loss, almost half of the. Next one. Then efficacy and safety of carbetocin. Carbetocin uh, is effective and safer than uh, carbetocin effective and safer than oxytocin. The efficacy is 14.5% of carbetocin and 14.4% of the oxytocin. Then safety is 4.9% of the carbetocin and 4.7% of the oxytocin. And non-inferiority establishment 1.51% for carbetocin and 1.45% for oxytocin. In short, carbetocin is better drug for managing PPH uh, and controlling bleed as compared to oxytocin. Next one. Uh, Cochrane review, carbetocin for preventing PPH. In this review, data from 11 studies involving 2,635 women were included. The author concluded that for women who had undergone C-section, carbetocin resulted in statistically significant reduction in the need for the therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to methergin in the prevention of PPH, for whom we have vaginal deliveries and associated significantly fewer adverse effects. Next one. Next. Guidelines. So guidelines, 2018 WHO guidelines, only one of the following could be used, like oxytocin, carbetocin, misoprostol, ergometrin, or oxytocin and ergometrin. For example, after uh, we can give prophylactic drugs after delivery, after either C-section or after normal delivery. For normal delivery, we give 5 units of syntocinon during AMTSL, active management, third stage of labor. For with carbetocin, we give 100 microgram either IV or IM. IM is much preferred for prophylactic. Then misoprostol can be given 600 microgram per vaginally or per rectally. And methyl ergometrin can be given from 0.25 mg to 0.5 mg IM. Then with oxytocin and ergometrin, either oxytocin 5 units can be given IV or ergometrin can be given 0.25 mg with this. These are the drugs we follow in India only. I don't know about Canada and other places how they use. In those places they use, like in Canada, they give carbetocin 100 microgram IV bolus, and in according to FIGO, carbetocin is also used. In Germany, France, they use carbetocin. They don't use this oxytocin. Next one. My experience with carbetocin. My experience with carbetocin, it was a good experience. I never had, whenever I gave prophylactic carbetocin, I never had a PPH. The cost of the drug is little bit expensive as compared to oxytocin. Otherwise, it's a very good drug. This is they have experienced the third stage of labor. Third stage of labor, which is nowadays we go for active management of third stage of labor. That is AMTSL. For third stage of labor, we give either 16 microgram of misoprostol, 0.25 mg of methyl ergometrin, or 1.35 mcg of prostadine or prostadine PGF2 alpha. Somewhere doing any profit also. Okay. So I have also done this study now during my PG. I have done a comparative study of effectiveness of reductal misoprostol with methergin with PGF2 alpha. Uh, but I also added one more drug. It was oxytocin. I did a comparative study between four drugs: oxytocin, misoprostol, PGF2 alpha blocker, and methylatone. When compared, methergin was having excellent results. I never had a PPH with methergin. The side effects were there, like patient had nausea, vomiting, headache, and also this hypertension, chest pain. But PPH was less. But with carbetocin, they have it has a very less side effect. So this study showed us like 3.5% of the participants were multigravida, while 20 to 12% had gestational age greater than 40 weeks. Mean maternal age, gestational age, duration of third stage of labor was compared in all the groups. Maximum amount of blood loss was seen among the participants who were in the control group. The maximum mean difference in HB was also seen to be 0.383 gram in control groups. Report side effects during the study include diarrhea, nausea, shivering, and vomiting in 1.5% of the patients. Postpartum hemorrhage and retained placenta were reported among 7% of the patients, and 2% population only. Then conclusion was misoprostol can be used as a safe and effective alternative against agent in the active management of third stage of labor. आगे करो ये नहीं आगे then
So,
carbetocin.
thank you so much, sir, for sharing your valuable insights. It was such a wonderful session. Now we move forward to the next part of our session, that is panel discussion, where we'll be having frequently asked questions and real-world scenarios which arise. So I would request both Dr. Suhail sir and Dr. Javed sir to share your valuable insights on the same.
Mhm.
So
Hi
coming to the
everyone,
first.
I'm Dr. Javed. Yeah,
Hello, Dr. Javed. How are you?
I'm good. Thank you. Thank you, Dr. Suhail, for inviting me here, and thank you, Hetero Healthcare, for conducting this useful webinar. So, as Dr. Suhail said, it is a very dreaded complication, PPH. As an anesthetist, I have seen maybe more than cases than him because I don't want to see him so many cases. It's good that you don't see such cases because they can they create a lot of panic once a patient undergoes PPH, then it is a nightmare. So we as Dr. says, sir, we search for every possible drug. Surgery is the hysterectomy or ligation, uterine ligation, that is the last option. So what we would need are good drugs. And oxytocin we have been using, but with a lot of side effects. And as you said, Dr. Sale, then comes the problem of storage of oxytocin. Uh, but of course, carbetocin is coming with a cost factor, which may be but with time, I hope it will be taken care of. And the thing is, I have seen now many gynecologists and many obstetricians using this carbetocin, and they have started using it for prevention. But yeah, as Shale said, it can be used for treatment also. I'm not sure about that, so maybe we can throw some light on that, whether we can use it for treatment of PPH. Of course, we can use it for prevention of PPH, just as we use oxytocin. We can use it for prevention.
What I did last time when patient had
Yeah.
PPH, we gave other drugs. Then the patient was still having PPH. Then I added this carbetocin. In that time it was a new drug, like in 2018. We gave carbetocin in 100 ml NS. We didn't give it directly. Then after giving in 100 ml NS in a labor room, I was working that time as a PG student in Rajasthan, 2017. That time no company had launched this drug in India. We were having these 10 to 20 vials. These were coming from some foreign country. I don't remember which one, because our HOD was that time giving us, she was telling us to study this drug. So that time we used to give first in normal saline, 100 ml normal saline. After giving this drug, the patient, most of the patients, I don't remember any patient after giving this carbetocin, patient had PPH. Everybody had this contracted uterus and atonicity was not there.
Okay, okay. Okay, thank you, sir. Moving to the next question, sir. What is the patient profile, Dr. Javed, sir, if you can share your views, what is the patient profiles in which we can anticipate postpartum hemorrhage in the patients?
Yeah, like we anticipate postpartum hemorrhage in patients who already have a history of PPH in previous pregnancies, so they are at more risk than patients who have multiple pregnancies,
Multiple.
like twin pregnancies or so multiple gestation. They also have chances of PPH. Then patients who have polyhydramnias, where they can also anticipate PPH in them.
PIH, PIH
Yeah,
patients.
patients who have any history of who are suspected to have any coagulopathies, then anemic patients also have more chances of PPH. Dr. Sale can add some more.
Race and ethnicity, like Asian women, they have more PPH chance of PPH as compared to women in Europe. And one more thing, the patient who are anemic, like patient women from the third world countries like India, Pakistan, Bangladesh, Nepal, etc., they have high chances of PPH because one of the reasons could be anemia. If the woman is anemic, they also have this edema also. If they have severe anemia, like hemoglobin is 7 gram, 6.5 gram, 8 gram. So the coagulation factors, they are not well formed in the body. So these people have more chances of PPH. One more thing, like if we compare religion, Muslim women have more PPH as compared to the other women, like Hindus or this. The reason is that they keep more babies. Muslim women, like, who have 7 babies, 8 babies. Nowadays the trend has changed, although, but if we compare religion, then Muslim women have more PPH. Then also, the other factors could be this multigravitar. You guys can add also. I don't remember now what are the other causes. Still, as far as I remember, these are the causes. Other
Of
causes,
course, one of the causes is the competency of the surgeon, as
ah,
we said, because
incompetency of the surgeon is
yeah,
not well
any
trained.
trauma, any
Ah,
trauma,
trauma. That could be the nitrogen.
trauma that
Yes.
can cause. So, and of course, as you said, the LSCS patients who undergo LSCS, they have more chances than normal deliveries. Patients who are undergoing normal deliveries,
Oh.
and then
See, the patient is previous scar, like she has 2 to 3 cesarean sections. The surgeon is doing the fourth C-section, then the chance of PPH increase. Scar thickness is weak, uterus is also weak, and also uh, during PGs, during residency, PPH occurs more in those people than rather than consultants, because the hand has grown good. We can do better surgeries.
yeah,
And
So, if the patient had multiple previous LSCS, then we can say that the chances of PPH in the same patient are more.
more.
Okay, okay. Thank you, sir. Moving to the next question. So, Dr. Sohail, sir, doctors generally use oxytocin for labor induction. So, in the same patient, in the same scenario, can doctor use carbetocin for
No, no.
prevention of postpartum hemorrhage?
Also for induction of labor. In such a case, doctors use carbetocin for so carbetocin can be given prophylactically to prevent PH, but it can't be used as a induction. It can't be used for induction.
Okay, okay,
It's,
sir. And if means oxytocin is used for induction, and then if the in the same patient prevention of postpartum hemorrhage is to be aimed, then can after
carbetocin
oxytocin
can
can
be
it be
used.
used?
Yes.
Okay. Dr. Javed, sir, your views on this?
See, there's no difference between oxytocin and carbetocin. These are the same analogs, but the efficacy for the receptor of oxytocin receptor now, carbetocin has more efficacy and it leads more release of calcium from the sarcoplasmic reticulum in the cell. smooth muscle cells. Actually,
Okay,
it's the
okay,
same drug, but it is heat stable with more efficacy towards the receptor.
okay,
Yeah,
okay.
as I said, I'm now seeing many of the gynecologists have started using carbetocin. In our part of the world, it was not used. I think I just saw it this year only. I mean, 25. They just asked whether carbetocin is available in the OT, so that
I keep
and
5 to 10 ampoules of this carbetocin in my drawer or in the hospital also. Sometimes if mishap happens, then we can use this drug.
Okay, okay, okay.
of course, the best thing is when I mean, from the ground level, only when the surgeons are feeling that, because maybe the research is not that much, but the surgeons are getting better results, so
Yeah.
that's why they are asking for it. I think that's a factor which proves that we have to use it more.
Okay, okay, okay. Thank you, sir. Moving to the next question, sir, Dr. Javed, sir, if you can shed some light on this. So, IV route, as it is the preferred route, if we modify the question a bit, are there any scenarios in which IM route would be preferred over IV route in patients? For
Yeah, of course. Um, uh, if the patient is having hypotension, so this can cause hypotension. So you don't want to give it IV bolus. Maybe in that case you can use it and an IM route. Okay, and
okay,
sometimes the surgeons themselves, most many
See,
I've seen,
normally
they
I
would
will.
prefer.
Uh,
Yeah, Hussein.
Normal IV route is preferred because if we are doing C-section, patient
Hmm.
is painted and rapid. Okay, so we have to remove the linen, then we have to give IM. So better IV is preferred because it has less side effects as compared to oxytocin. We use
okay,
normally 5 to 10 units, 20 sometimes 20 units, 25 units of syntocinon IV in managing PPH in a patient with atonic PPH. Why can't we use this carbetocin? We should use
Yeah.
carbetocin with less side effects as compared. Doctors are scared in giving uh, this carbetocin, but they are not scared to give oxytocin. So we have to change the mindset of the doctors. We have to tell them. So this presentation is actually for the awareness of the doctors. So doctors should get.
Out almost everything in his PPT also, and this. But of course, last would be the option would be hysterectomy, and that would be the last option.
That would be a disaster.
That would be a disaster. But I I've seen people not responding to any kind of rest. But one patient I saw, which was in which home hysterectomy was done, they did not use carbetocin because I think it was not available or
At that time.
uh,
See, normally I am doing surgeries from 2014. From It is 2028. It has been 10 years almost. From 10 years, I never had to go for hysterectomy in 10 years. And I do lots of C-sections also. There was a time I used to do 17 to 18 C-sections in 24 hours shift in hospital, government hospitals. But I never had this because surgically I'm better trained. Mm, I can go do internal. Last I reached was when I had to go for interlinear cartilagation.
okay, okay,
And most of the 70 to 80%, if you keep this PPH can last 70% of the PPH can, even after giving drugs, if the patient doesn't respond, 70 to 80% of patients get managed with PPH can only, and 5-10% you can use Burkitt's balloon. It is a balloon which we can put inside the uterus. Most of the patients get managed with this.
okay. Surgery option is not required in almost all of the cases, we can say.
I never had this type of scenario till now. Most of the
Okay,
cases were managed with PPH can and Burkitt's balloon till now. Only once I had to go for interiliac ligation. Just one patient.
okay, okay,
Uterine artery I have done many times, but this क्या कहते हैं इसको interiliac artery ligation. Once I was in Delhi, there I was practicing there. That time only I once had to go for interiliac ligation.
okay, okay. Thank you, sir, for sharing your views. Moving to the next question. So, sir, what are the Dr. Suhail, sir, what are the advantages of carbetocin over other uterotonics? You have already mentioned all the advantages.
It
Any
has less side
additional points
effects.
that you would like to?
It is less side effects as compared to other drugs. See, Mithergin is a wonderful uterotonic agent. I have tried each of these drugs personally over a period of 3 years. I have done a study with misoprostol, with prostadin, with this uh, Mithergin, oxytocin, over 3,500 patients. I did a comparative study
Oh,
myself. Taken 3,500 patients. I used to count this gauze, how much gauzes are get wet after delivery. I have to I used kidney tree also to check the amount of blood loss after delivery, either normal delivery or C-section. How much blood? Then methadone is a wonderful drug, but the side effects are very high. Patient can have MI also. Normal
okay.
patients, the patients having blood pressure of 120 by 80, its BP can raise up to 180, 190 systolic, and diastolic 100, 110.
Okay. Okay.
So in a patient
So
also stroke
it
can happen. Stroke can happen also. Okay. With prostadin injections, patient can have embolism and then diarrhea. After delivery, most of
vomiting,
the patients they
vomiting, vomiting is a common
vomiting
side.
also. Vomiting is a common
Yeah.
side. Vomiting and BP. These are the side. But with carbetocin,
And
almost
of course, you cannot use prostadine in patients who have any history of asthma or such
asthma,
allergic disorders. Yeah, you have to be very careful. But
Okay. Okay.
carbetocin you can use.
Okay, okay. Thank you. Thank you both of you for sharing your views. Moving to the next question. So, should carbetocin, so yes, Dr. Ravit sir, should carbetocin be kept as a reserve drug or should it be used as a first line drug?
first line, I guess. If companies
Yeah,
raise the price of the drug,
So,
yeah, maybe
means it,
maybe it is becoming more popular now. As I said, in the last year or 1.5 year, I've seen. Yeah, I mean the surgeons asking for it, whether it is available. Then, so I think it should be now kept as a drug.
first line drug,
Uh,
yes.
yeah, first line,
okay,
of course,
okay.
first line.
Yes.
Okay.
Moving to the next question and the last question. So, Dr. Sohail, sir, means both of you, please share your views on this. Dr. Sohail, sir, if we have to summarize the entire thing and the efficacy and safety of carbidocin on your experience, just in brief, you have to summarize would you tell to our delegates?
I will see most of the deliveries in India, they occur in government hospitals, in government setup. So you have to make it available in government hospitals. The cost of the drug is high as compared to oxytocin. So making it available in government hospitals, it needs huge amount of money. So maximum deliveries in world, they occur in India only.
Okay.
So if government can subsidize the drug and
In Amir,
make it available for the common people, then I will say that
you know,
carbetocin is a better drug and wonderful drug as compared to oxytocin. But if you can't make it available, what is the fun of?
Correct, 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 sir. Dr. Javed, sir, your views on this?
I'm sorry if there was any disturbance or I forgot to mute. Yeah, of course,
No,
I
no
agree
problem,
with
Dr.
Dr. Suhail. So I think with time we will be needing carbetocin just like we need oxytocin. So maybe it will be replacing oxytocin in future,
20 to
and
30
it
years
has.
if government
Pardon?
subsidizes the drug. If the
Yeah,
cost of the drug will be reduced and it
I
will
think I
be
think
available
I
in
think
government
it will
setups.
reduce with time. I think it will reduce with time.
See, we
So
are using in private setups, but none of the government hospitals in India is using this drug. The reason is that सरकार तो नहीं देती ना ये दवाई. We can't bring the drug from outside and give it to the patient inside a government setup. लिख के भी नहीं दे सकते,
right,
है कि
True,
नहीं?
true, sir.
हाँ, सरकार में सरकारी अस्पताल में सरकारी ड्रग चलेगी, वो भी अवेलेबल होनी चाहिए लेबर रूम या ऑपरेशन थिएटर के अंदर.
of course. Yes. So
Correct,
that is
correct.
you are handicapped there. So
So तो हम
So,
लोग को इतना मौका भी नहीं मिलता है कि हम इसको अच्छे से ट्रायल पे लेकर जाएं फिर देखें। हम ट्राई करते हैं तो फिर प्राइवेट हॉस्पिटल्स कितनी डिलीवरियां होती है, उतनी तो नहीं हो सकती जितनी गवर्नमेंट सेटअप में होती है।
correct, sir.
ये
So,
चीज
so we can say that cost remains the only challenge for now. Means otherwise, for efficacy and safety, the drug has acted very
drug
well.
is better than oxytocin, yes.
Okay. So, thank you both of you for sharing your insights and valuable views regarding carbetocin's efficacy and safety. So, this brings us to end of our session. So, again, I would like to thank both the speakers, Dr. Sohail sir, Dr. Javed sir, for sharing your insights regarding where carbetocin can be used, what are its benefits, and how safe it is. So, I would also like to thank all the delegates for their active participation and engagement into the meeting. So, yeah, this marks the end of our meeting. Again, thank you both the speakers. We can close the meeting.
Thank you so much.
Thank you everyone. Good night.
Good night, sir.